Good evening, everyone. Welcome to another series of educational webinars by HCH. ICU. When I started my job in ICU as an ICU specialist, बड़ा फैसिनेशन था. क्या बड़े बड़े बेड्स थे, मॉनिटर्स थे, प्रोसीजर्स थे. ऐसा लग रहा था मतलब बहुत ही कुछ ऐसा फ्रूटफुल कर रहे हैं जो कोई और नहीं कर सकता. बस लिटिल लेस देन सर्जरी. ओटी में शायद उससे ज्यादा फील आती थी. But once I was talking to a patient who was in my ICU for more than 3 months, young patient, रोड ट्रैफिक एक्सीडेंट था, जान बच गई थी, अभी बहुत कुछ और हो रहा था. और मैंने उससे पूछा कि कैसा लगता है यहाँ पे. रात को नाइट ड्यूटी पे था. मैंने पूछा कैसा लगता है यहाँ पे. कहता नींद नहीं आ रही, पता ही नहीं चलता दिन है कि रात है. हर समय टूं टूं की आवाज आती रहती है. वही फेमिलियर डॉक्टर फेसेस और वही फेमिलियर नर्स फेसेस रोज दिखते हैं. घर वालों से मिलने के लिए तरस जाता हूँ, दोस्तों से कब से बात नहीं हुई है. कभी सो जाता हूँ, कभी उठ जाता हूँ, इन एंड आउट चल रहा है. मुझे समझ नहीं आ रही मेरी जिंदगी चल कैसे रही. कभी कोई ट्यूब निकाल देते, कभी कोई ट्यूब डाल देते. एंड दैट इज द डे आई रियलाइज्ड that how different is the ICUs for a doctor, for a healthcare provider, and how different for that person on that bed for so long. और कोविड ने तो इसको और एक्सेंचुएट कर दिया. The long COVID syndrome, people who went into ICUs, the doctor tries their level best to get them out of the ICUs, right? But it took their own toll. And just imagine that this patient who's into the best of the ICU, best of the doctors, round the clock, nurses, technicians, dietitians, physiotherapists, respiratory therapists, discharge करने के बाद, the whole responsibility is with the family. And if something goes wrong, you're back into that ICU again. So today, luckily, we have one of the experts from the western part of the country, Mumbai, Dr. Varun Deshmukh, who's going to tell us कि क्यों पेशेंट्स लंबे समय तक रहते हैं और ऐसा क्या करना चाहिए कि वो सेफली घर जा सके, उनकी फैमिली उनको मैनेज कर सके और वो वापस आईसीयू में नहीं आए. सो आई वेलकम यू डॉक्टर वरुण.
Thank you so much. It's a good opportunity to reach to a large number of people through your platform, and I thank you for that.
Great. So let me introduce Dr. Varun. So Dr. Varun is the consultant and chief intensivist at Jaslok Hospital and Research Center, Mumbai. He's done his MBBS and MD anesthesia from Ahmedabad, and then done his fellowship from National Board in Critical Care Medicine from Bombay Hospital in Mumbai. He handles a team of 6 intensivists, 20 clinical associates, manages the 50-bed ICU, which is quite large, has all types of patients, medical, surgical, neurological, cardiological, nephrological, and is also into very specialized management of ECMO, जो आजकल सबने सुना ECMO, LVADs, एक ऐसी मशीन जो हार्ट के बदले में लगाई जाती है और लिवर और किडनी ट्रांसप्लांट के पेशेंट्स. He's also done his European diploma in intensive care medicine, which again is a very big achievement. So a lot of laurels, lot of education. Let's learn from him. Welcome again, Dr. Varun. So Dr. Varun, tell me कि हम बोल रहे हैं लॉन्ग टर्म आईसीयू केयर, लॉन्ग टर्म आईसीयू, वो क्या ड्यूरेशन है जो इस लॉन्ग टर्म को क्वालिफाई करती है और किस तरह के पेशेंट्स हैं जिनको लॉन्ग टर्म रहना पड़ता है आईसीयू के अंदर.
So generally long term as such कुछ उसका definition नहीं होता है, but generally जो patient ICU में आते हैं, generally they come with any organ dysfunction, sometimes single organ dysfunction, sometimes multiple organ dysfunction, and as an ICU physician our goal is to treat and treat that organ dysfunction, get them better and shift them out of the ICUs. But sometimes what happens is the patient's organs do not have enough reserve, or for various reasons we cannot get them better in a limited number of span of days. So for a surgical case, probably 3 to 5 days would be average ICU stay. For a medical case, sometimes up to a week would be an average ICU stay. So for that particular indication, if patient has to spend longer time than that, then we would start thinking that probably this patient is staying in the ICU for a longer duration. So it varies from indication to indication. But if the stay extends than our expectation at the time of admission, then we say that okay, this patient is having, so some unanticipated reasons have come up, some things have gone wrong, and the patient has to spend longer time in the ICU. In these situations, we call it as a longer ICU stay.
Right. And what kind of patients are these? What makes them stay longer in the ICUs?
So these are various, these are group of patients. So some patients who are operated, sometimes they develop operation related complication, sometimes they develop infection. Suppose neurological patients get admitted and some complication happens related to the neurology. Sometimes the recovery is not as fast as we expect it to be. So then these patients require further monitoring, continuous care, and they spend, sometimes the physiotherapy and rehabilitation takes longer time. And in that situation also, we don't feel confident to send them to the room or send them to the out of the ICU. So we keep them in the ICU. So generally, these are the common reasons, I would say. There can
Very
be,
apt.
yeah.
Very apt. I still remember when we were doing the ICUs rounds in the morning, हमारा एक क्राइटेरिया होता था कि इसको रूम में शिफ्ट करेंगे तो ये वापस आ जाएगा 2 घंटे में, तो मत करो अभी, राइट? लेट कीप इट
In
another
fact,
part.
it is a quality indicator for various
Right.
NABH and all.
Absolutely.
कि अगर पेशेंट 2 दिन में वापस आ जाता है आईसीयू में, that means he should not have been sent in the first place. So
Yeah.
it becomes a quality indicator for us also.
So, but what are the challenges which the patient faces due to the long stay in the ICU?
So first and foremost is the financial challenge. Of course, in present scenario, if you go to a tertiary care hospital, you are looking at 30 to 50,000 rupees per day. And if the patient is on advanced supports on modern machines, everything is expensive. So even each day extra spent in the ICU creates a huge burden on them. That is the financial aspect. The other aspect is the emotional aspect, the emotional toll that is taken on the family. And for patient, from patient's point of view, if we think, for the patient also, there is a lot of stress, anxiety, what is happening, what is going to happen. So for the family, there are multiple various reasons which will affect them if the stay gets prolonged. Mainly I would say financial and emotional reasons, the anxiety related to that, and sometimes they go into depression following prolonged ICU stay. Their social life also gets affected. The patient's life gets affected, that is understood, but the family members who spend most of their time in the hospital, their work life gets affected, their social life gets affected, their family problems start uh, uh, in their personal life. So these are the problems that we as a doctor, we don't see them, but these are the actual problems that over the time I have come across in various families.
Right. And that brings me to point that as a doctor, no one would want our patients to suffer like that, right? So
Yeah.
then what is the point where you start thinking that this patient is now ready to be discharged from the ICU?
So generally, our goal is that the patient should be able to maintain his airway. In simple terms, the patient should be able to breathe comfortably. We may not be able to stop the oxygen completely, but it should be at a low level, maybe 1 liter, 2 liter. Patient should not have episodes of breathlessness or fall in the oxygen saturation. Patient's pulse rate, blood pressure should remain in a stable range, and they can be managed with tablets. No continuous injections should be needed. Patient's kidney function, even if patient is on dialysis, the kidney function should remain at a stable level. We can do intermittent dialysis as per need. Patient need not be in the ICU. But if the patient develops other problems related to kidney functions, which are called uremia, the symptoms because of kidney functions, then we may need to monitor such patients in the ICU. Or patient with liver decompensation. So we try to make sure that the patient's sensorium is reasonably intact. Patient's vital parameters are stable. Patient's oxygen requirement is either abolished completely or it is less manageable at a ward level or at home level. And physiotherapy and mobilization, patient should be able to do their basic uh, things like passing urine, having food. If they are given food, they should be able to have their food. If they are on feeding, then the family should be confident in maintaining the feeding regimen at their place. So we look at all these things, how they can be managed at home or in the ward. And if we feel that the parameters are acceptable, the sugar level should be reasonable. There should be no wide fluctuations, very high or very low sugars, because otherwise these patients may also end up back into the ICU. So these are the things that we look at. All the basic organ functions should be, the function should be brought to a reasonably stable level for them to be shifted to the ward or maybe to home.
Right. And so then there is a lot which goes in viewing that this patient should not get back to the ICU, right? And I
Right.
think that's where the role of post-discharge planning comes, which is the topic for today. So what are the steps we take for doing that planning? What are the do's and don'ts? What is the training of the family? What is the instructions given to the patient? How does this all happen so that the patient does not land up again into the ICU?
So this happens at multiple levels. Generally, when the patient is in ICU, more than one specialty doctors are seeing these patients. So first, amongst the doctors, a consensus has to be made that okay, now the patient has regained certain level of fitness, and then he is good to go to the out of the ICU. So that is the first step that we amongst ourselves decide that now. Or sometimes what happens is because of the clinical condition, the expectations has to be set a little low, that we cannot expect every patient to walk out of the ICU. So if there is a neurological case or if there is a prolonged ventilator related case, then we have to come to a reasonable expectation. So at some point we decide okay, this patient may require months of therapy, months of weaning from ventilation, or months of physiotherapy and rehabilitation therapy. Then we have to take a call on that. So the process start at that level. Then we speak to the family, whosoever comes with the patients. We give them idea that what all sort of care is needed for this particular patient, what all things we are monitoring in the ICUs, and we give them confidence that okay, see, these are the things which are beyond a normal healthy person, but they can be managed at home. And if you are willing, looking at the pros and cons, if you feel the confidence, we can plan the discharge. So that takes family also a few days to get used to this concept of taking the patient home, because in particularly in Mumbai, people live in small homes, and many people live in a small congested area. So it is very difficult for them to get a sick patient to their home, and that itself becomes a trauma to the family. So they also need to come to terms with this situation. So we explain the family, gradually they come to terms. At the same time, we have to give them confidence that all these things will be managed at home and the care will not be compromised. But keeping the patient in ICU, we are not helping the patient, because certain things will improve over time, and keeping in ICU will not make them improve faster. So by making them understand this and arranging good support at home, sometimes we have to arrange a BiPAP machine or oxygen concentrator or these sort of things. Sometimes we need to arrange nurses or ward boys. Sometimes there are companies which provide all this care at home. So we take help of all these sort of resources, and we help them. And also we give a proper discharge summary. We write down the things to look for, important symptoms to look for, and if any such symptoms happen, immediately contact the concerned emergency team or the physician who is the main doctor of that patient. So we give them a plan to manage at home, and we give them the SOS, this help material also, that in these conditions, please bring the patient back. So that increases their confidence. And the most important thing is having a realistic expectation. So if the sometimes what happens is the family is not very keen on aggressive treatment or putting the patient on a ventilator. Patient may be suffering from a cancer, or maybe having multiple metastases or something advanced neurodegenerative disease. And then if we send the patient home, and suppose if the oxygen level comes down, then also if the main idea is not to make the patient suffer, then that same idea has to be continued. And probably in the surge of emotion, sometimes these patients are brought back to the hospital. So we give them education on that also, that see, our goal is, if our goal is to keep your patient comfortable, then till the end we should keep the patient comfortable, and we may not rush him or her back to the hospital for small little things. And some patients have a wish to spend their last time at home, and so that also has to be respected. So if the disease is such that there is not much we can offer medically, then we respect those wishes, and we may have to send them home. So all these things go through our minds, and we do like this. That's the usual process.
So very, very interesting. In fact, one thing I would like to share is that we have already reached more than 500 people in the first, I would say 15 minutes only, right? Which is a good thing that the topic is interesting enough to attract more people. Second, I would like to share two experience at HCH. We are now the largest hospital outside the hospital, where I think the longest patient which we have treated on ventilator at home is around 22 months, right? A patient of motor neuron disease, and not a single bed sore, not a single tracheal thing, no HIs. And similarly, very interesting thing you brought of end of life care. I want to breathe my last at home, which is that dignified death, not away from my people in the ICU. We did a study of around 250 patients over a year, which we had treated on home ICUs, and around 25% of them were end of life care, and they were all supposed to go in 2 3 days. Our mean survival rate was around 70 days, which we when benchmarked to a study in Japan, it was 44 days there. So I think a good quality care led by a very competent physician can give that quality of care, right? Having said that, in the West, in USA, in South Africa, in Australia, what we have seen is that such patients are sent to transition care facilities because they cannot be immediately sent at home. What is your view on that? And are there any transition care facilities already available?
So there are high dependency units which are called HDUs. These are the units where the patients needs to be, where the patients are shifted when they need to be monitored more closely than a ward. The nursing ratio is better per patient. The monitoring is better. But generally they are not on organ supports. So we send such patients to the HDU. The only thing is the bed capacity of an HDU is very less. I am sure in all the hospitals, probably per 10 ICU bed, there would be one HDU bed. But in real sense, we need more HDU beds rather than ICU beds. And if we think logically, then sometimes some patients unnecessarily spend longer time in ICU because they are not fit to go to ward and there is no bed in the HDU. And we can't take the risk of shifting these patients to ward. But at the same time, we are denying bed, an ICU bed, to an eligible patient who is really in need of an ICU bed. So from that point of view, also, I feel we need to think. So HDU is one option that I am aware of, but it is very limited in numbers.
Yeah, and I think that there's a huge need of these out of hospital transitional care facilities also, because what happens is either these patients have an option to be in the HD or ward, or as you said, they're already emotionally and financially drained. They take this call to either the treat the patient at home, right, with a cheap and cheerful solution, rather than realizing that this will again get them into the hospital, or they get to, if they are from somewhere outside, they get to a guest house or a nursing home, right, where again the care is getting compromised, and that's the only thing which should not get compromised, because that will again get them into that vicious cycle. So
Right.
there is something. So we spoke about the drainage of the family, right? What all does the family need to know when they're taking these patients at home?
So the family needs to have a realistic expectation. What we generally do is let them spend 1 or 2 days in the ICU itself when we are planning to discharge such patients, and let the care of the patient be transferred to the family. The nurse who is looking after the patient, the physiotherapist who comes to attend the patient, will show the family also what they are doing, and we will let the family also do the same stuff and let them gain more confidence. So once they are they do it themselves, they realize that sometimes thinking about it and actually doing, there is a big difference in the two things. So we encourage them to spend, sometimes they get caretakers or they get some private nurses, so we let them spend some time in the ICU and we train them from our staff, so that they are more confident and their competence also increases when they reach home. So probably that is something which is going to help the families.
Have you observed any post-traumatic stress disorder or any other mental issues with long-term patients when they go home or with the family? And if yes, then what do you suggest for that purpose?
So yes, actually, not very in India. Talking about mental health is very small set of people who really come out and talk about it. I have come across few patients or families who are not able to adjust at home after reaching home. Sometimes the family members complain that the patient is as such fine, his parameters are fine, but the behavior is not as per the earlier behavior, or the patient is not taking interest in the usual things that he or she would do before the ICU hospitalization. So their personality changes sometimes. Sometimes their attention span is less. When the family members are having a chat, sometimes the patients don't get involved in the chat. Sometimes they in between the chat their focus changes. So these things are definitely, I have seen patients, the relatives complain about. uh, that is perhaps the post traumatic stress disorder, the emotional, and some patients complained about nightmares after going home, that they in their dreams they get bad dreams that somebody came and gave an injection and then the patient choked or something of that sort. So that is also something which I have come across. So probably this is the post traumatic stress disorder. And probably talking about it uh, with the family members, giving them idea that this also could happen, and talking amongst the, maybe creating a patient groups where the ICU discharged patients can share their experiences. These things may help them, but probably spending longer time at home is the only solution. But for that, they need to have the confidence to go back home. These things happen because one thing is day night's circadian rhythm is lost. So in the ICU, lights are on most of the time, alarms are beeping most of the time, so day and night differentiation is gone. In many ICUs, there is no window to look out, and they don't get the outside view what is happening. So patient don't doesn't see sunlight for many days altogether. So this leads to disturbance in their sleep and wake cycle. Sometimes the nursing staff is speaking some different language. Most of our nurses are from Kerala. So in spite of their best intention and their best efficiency, the patients who do not understand their language, sometimes they feel disconnected. And all, some patients have a hearing or vision problem, they use glasses or hearing aids. So these things also, when it is not there in the ICU, whatever they see or perceive, sometimes they get a sense of paranoia in that. And sometimes it manifests while being in the ICU, sometimes it manifests after going home. So that is something which is very important to recognize in the first place, and then we can come to treat it.
So you also in your practice would have seen readmissions, right? People coming back after discharge from home. What are the top few reasons of getting a patient back to the ICU?
So probably the most important reason is the family not able to understand their expectation being very high, and when they reach home and they don't see their expectation being met, they bring the patient back. So I would prefer to counsel the family even before the discharge that, look, we are having these expectations from the patient, and don't bring the patient back. And if they feel that, okay, we are having better expectation, then perhaps better to keep the patient in the ICU for a few days more, get the patient's recovery to a even better stage, and then perhaps plan to shift out. The second thing is having freak panic issues, like suppose somebody has a pulse oximeter at home and temporarily the pulse oximeter had shown a reading of 70, then they would suddenly panic and bring the patient home, back to the ICU. Or sometimes the patient would complain of acidity or some chest discomfort, and they would bring the patient immediately. So these sort of things happen, and I feel probably giving them education before discharging them will solve these problems. Sometimes good care at home. Sometimes what happens is the care at home is not up to the mark what they have seen in the ICUs, and they don't feel, it doesn't inspire confidence in them. And then they talk to the caretaker, and the way they are answered, they, based on that also they become afraid that, okay, how this person can manage my loved one at home, and they bring the patient back to the hospital. So probably letting the caretaker spend some time in the ICU and discussing all these things in detail and giving them a realistic expectation will avoid probably 50% of the hospital readmissions. Of course, some cases are really genuinely such cases where the problem is genuine and it has to be addressed. So that is fine. That's what we expect. Some, not all patients can be managed at home, and we expect certain number of cases will come back for the care. But I would say at least 50% readmissions can be avoided if proper counseling and training is given to the family members.
Absolutely, absolutely bang on. It is one is the fear factor, other is the negligent care, and then definitely patient's health deteriorating. And in negligent, you very well addressed key first part is more of understanding, counseling, realistic expectations. But what I've seen in negligent care, where people tend to compromise on the care outside the hospital, they end up with bed sores, with tracheal tubes blocked, with falls, with fractures, with stress fractures, critical care neuropathy, and whatnot. And you must have seen all that, right? And you also said that very, very subtly, you said that it's not only hiring a nurse or attendant which is going to solve the problem. The patient has definitely nursing supportive needs. The patient has rehab needs. The patient has to again start speaking. So speech therapist needs. Patient has to get back to job. The occupational therapist needs a doctor monitoring it, right? And definitely somebody taking accountability that whatever equipments, medication, labs need to be done, like in a hospital, there is an accountability. It needs to be done there, and I think that's something where doctors like you get a lot of confidence that I'm handing over my patients to a competent team, and that's what we boast about here in HCH of doing and being the pioneers of ICU at home. But what is your opinion on this multidisciplinary team approach for managing this patient post discharge?
I think that is the way the case should be. Any case should be handled. If the patient is hiring a team to look after, then probably, as you said, one person should take accountability and should manage all the things, all the needs, starting from the need of medicines to providing physiotherapists to daily medical, the doctor's rounds to nursing care to the other the care of a ward boy or aya bai or that level of care. And as you said, occupational therapist or speech therapist, these things are also needed for some of the patients, and probably that is the way to go in future. So that is very essential, and it will definitely improve the readmission, reduce rather the readmission.
Right.
Because
And
we don't like the patient to come back to the ICU for trivial reasons, or because of the poor care being provided at home, and whatever condition we sent the patient in, the patient comes in a worse condition, then probably it is even difficult to manage these cases.
right, absolutely, and I think that's where the role of quality care and accreditation comes into place. And HCH again being the first accredited organization, our learnings have been with doctors like you that every doctor wants a quality care. But you mentioned a very interesting thing: rounds, daily rounds. Now, how effective are, see, it's very difficult at home for a doctor to go and visit every day, right? And what we found that the solution which came handy was e-rounds by the primary doctor, and then 24-hour intensivists monitoring these patients on one command center, right? What how do you think these are effective, not effective? Do they add value, or what are the pitfalls of this monitoring?
So I do think it is helpful, because it is practically not possible for a person who is having a full practice in the hospital. Patients may not be able to spend time at home for home visits, or sometimes I finish my round at 8 o'clock and I come back at home. I do not have courage to go to somebody's home and see that patient. But at the same time, I do worry about the patient, what will happen, or how the patient will be managed. So if somebody who is competent, who is taking care of the patient, and if I get a phone call or I get a video call to update me about the situation, probably that is it is sort of a middle way of the things to do the things. And probably I think it is a good solution than not being able to reach, or uh, having no accountability at all. For 24 hours intensivist, I am not very confident in that system, because the person who is at the bedside needs to be competent for that. The intensivist from far may give you some suggestions or advices, but eventually it has to be followed. And whatever information is fed to the intensivist, perhaps that will make the intensivist take a call. So I have known few centers where they do tele ICUs, and they have excellent high resolution cameras and all. So they can even see the pupillary reaction to that extent. So I am aware of that, but I have personally not had much experience on that, and that's why probably I don't have much confidence in that system. But definitely rounds at home and e-rounds or video consult, that would be perhaps what I would prefer at this point.
Absolutely bang on, Dr. Varun. And I think that's where very aptly you have put it, that the information which is coming to the intensivist has to be as accurate as possible. And you might not be able to get those lease lines and high resolution cameras at home, but if you have a very well trained nurse who exactly knows what to look and what to communicate, I think that solves half of the problem, because these nurses, physios, and all the multidisciplinary teams spend much more time with the patient than all of us together. And that's where I would again say we all, hospitals and out of hospitals and home care, struggle with that clinical quality, and we need to invest a lot into it. So COVID has been a very, I would say, interesting and different experience for all of us. Hats off to you, doctors like you who went into the ICUs dressed like robots and managed from the front, right? And we also, as I said, we managed lakhs of patients through remote monitoring at home through nurses, doctors, where we were able to reduce some burden on the hospitals by not allowing these patients to come to the hospital. We had in 10 lakh patients, we had 97% recovery rate, right? So my question is that is post-discharge care for these COVID patients who are in ICU is different? And if yes, then what are the two, three things these COVID, because I see that long COVID syndrome, long steroid, right? What are the special precautions these patients should take?
So, because of the COVID, what we see is many patients do not recover from the weakness or muscle pain or body aches for a very long time. Sometimes it takes 2 or 3 months to them for them to feel normal. Sometimes the patient intermittently has headache. Some patients, even if the saturation is normal, their sense of breathlessness does not go. They feel that there is something wrong. I'm not able to breathe well. Sometimes patients are discharged on steroids or on certain medications which can damage their liver or kidneys. So these things have to be monitored. So we do give them the prescriptions and advices to follow up. Sometimes we feel that somewhere in the line the communication is missed and patients get lost to the follow up, and we miss these things. So probably some patients are on steroids, so their sugar, they may not be diabetic to begin with, but with steroids, with a prolonged course of steroids with high doses, they behave like diabetics, and we have to actively manage their sugar levels. And on reducing the steroid dose, sometimes the diabetic medications also have to be adjusted accordingly. So all these things need not have an ICU care, but these things are few things which have to be monitored even after the discharge from the hospital or from the ICU, and that goes on for 3 to 6 months in many of the cases. These patients also require physiotherapy. We have a specialized pulmonary rehabilitation team in our hospital, but I'm not sure in whether it is available so freely everywhere in the country. But that is also something, their respiratory muscles need to be trained again to regain the strength that a normal person would have. So these things require a few months of time, and probably these are the common problems that I see with the COVID patients.
So, Dr. Varun, we have already reached more than 1,000 people, and more than 100 people have shared this video. I think that speaks volumes for the content which is being delivered and the way you are telling people what to do, what not to do. My last question of today is, you said ki, you need to get that confidence that you are handing over your patient to somebody who's competent enough to take care of all the care. So if you were to send a patient home, what, and you want to send that patient early, right? What are the three, four things which you look into a home healthcare partner or as an organization like us? What are those three, four things which you would ask your patients to look into before they decide what to do?
So the most important problem that I feel is the lack of the nursing staff or the support staff does not show up on the first day itself. So suppose it is committed that from today evening you take over and nobody comes up at the designated time, and then they tell us that okay, there was some problem, the person could not be arranged, or somebody fell sick and they could not come, or so for them it may be a genuine reason, but we encounter it so frequently that I am made to believe that probably they are lying most of the time. They may have eaten more than what they can chew, and then that leads to compromise in the quality of care. So most important thing for me would be to have a continuous support and commitment from the healthcare provider for the patients, and there should be no lapse in the no absenteeism or no lapse. Suppose somebody genuinely falls sick, then also there should be a replacement on time, and there should be no compromise on the patient care. So that is the most important thing that I tell my patients attendants also to look for. That there, the other thing is continuous uninterrupted supply of medicines and equipments. Suppose oxygen is required and oxygen cylinders are kept in standby, then there should be no time where the current cylinder is about to finish and next cylinder is not available and patient is hanging in anxiety. These situations should not arise. And if such situation arises, the patient will keep on calling me again and again for these small little things, and that will make my life also more difficult. So probably next time I will not recommend that particular service to a next patient and that thing will be crossed off my list.
Very interesting, sir. Very interesting. I think what you have voiced is continuity of care, whether it is manpower, whether it is infrastructure, whether it is support. So let me give our viewers some confidence, right? I think all this at one point leads to a dent in the reputation of the doctor, because doctor कहता है यार मैं क्यों फालतू में ये phone calls लूं, मेरे पास और काम कम है क्या, right? I am responsible for the patient when you are there, right? And you come here if you want to, right? At the same time,
And they feel that since I have recommended a particular service, that way also it creates a dent on my reputation, that doctor, you had recommended and now this person has not come, so what should we do? So I am really not involved directly in this, and I have just probably as a helping gesture I would have recommended somebody, but then I also end up in a difficult situation.
agreed, sir, agreed. And that's where I'm trying to give this confidence to our viewers that patient satisfaction is something which everybody talks of, right? But there has been no objective measurement. In hospital also, we just want to tell them, how will you rate our services, right? But at HCH, when we encountered this problem, because we're in a distributed environment, right? What we started doing was that we instituted this very, very stringent criteria of calling every patient and asking, would you recommend our services on a scale of 0 to 10 to anybody else? Don't give us our experience. If our experience is good, you will give us 9, 10. If it is okay, you will give us a 7, 8. But if you're giving us below 6, that means we didn't do a good job. And every case where we got less than 6, and because this question is so different, rather than saying that rate my services, you're saying, will you recommend my services? So this is something, a concept called net promoter scores. And because of a stringent focus on this, for the last 7 years, we have been upwards of 65%, right? And I think that becomes the biggest differentiator, where the doctor knows, yeah, I am working with a credible team. They have not chewed more than what they can eat, right? And when you have nurses on your role, when you have backups, right, the continuity of care is the basic and not something which is required, right? And that's why I think it's not easy to execute this ICU care at home or the post discharge care at home, and people should refrain from getting a so-called nurse or a so-called cheap equipment and then try to manage everything and then go for job and leave everything to that person, because that itself is a recipe for disaster. So that's I think you have brought it out very well, Dr. Varun. I know you are a very, very busy doctor managing so many critical patients. I won't take much of your time. Thanks for coming on this show. Thanks for educating our people and telling them the value of a planned discharge, right? And what are the problems of staying in the hospital and how do you come back? I think it was a very, very valuable advice to all the people on this show. Thank you so much for your time, and thanks for all your advice.
Thank you so much. Have a good night.
Thank you.